that we're still encountering in the country, specifically Lassa fever, meningitis, yellow fever, especially in the context of our prevention programs. We know that those three diseases and some others occur at different points of the year. But we're on the downward trend now, but again, we need to start preparing for these diseases where they are likely to occur. So we're going to add that to the cholera situation and to include again what we call antimicrobial resistance, which has become a global problem.
Let's carry on. Please, can we all set? Let's take 1 minute to set ourselves properly so that when the DG starts, we don't have to interrupt. We are ready already. So if the DG sees that you guys are ready, we will continue.
Thank you. Are we ready? We are ready. Like I was saying, apart from cholera, and to update you on plans on a couple of diseases with respect to our seasonal calendar, then one other issue that has become a major global threat, which is antimicrobial resistance, which unfortunately we have not addressed appropriately in this country. It's becoming a major issue. Then Mpox came in. So we decided to add Mpox to what we're going to talk about. In the next couple of weeks, again, we'll be expatiating on each and every one of these. This is just to enlighten you on, to let you know precisely what we are doing in Ncdc. So let me just welcome you all to this press briefing to provide updates on the ongoing outbreaks of cholera, Mpox, and other events of public health interest, including antimicrobial resistance. The Nigerian Center for Disease Control and Prevention has been closely monitoring several endemic diseases in our country, including Mpox, which has been declared a public health emergency of international by WHO or continental concern by African CDC, both in the last 2 days. So far, about 2,863 confirmed cases and 517 deaths across 13 African countries have been reported in 2024 alone. These were statistics given by Africa CDC. This alarming increase is linked to a new strain of the Mpox virus, which emerged in eastern Congo and has since been detected in other countries, including Kenya, Rwanda, and Uganda. In Nigeria, cumulatively, a total of 39 confirmed cases out of 788 suspected cases. Let me read it again, 788 suspected, and we were able to confirm 39 cases. And no deaths, 0 deaths, have been recorded across 33 states and FCT from the beginning of the year. Some of these states, Bayelsa recorded 16 out of the 39, Cross Rivers 5, Ogun State and Lagos State 4 each, Ondo and Ebonyi State 3 each. These are the states leading the pack out of the 39 cases. Noting the significant concern of the ease of cross-border transmission, this press conference is part of the efforts to intensify our coordination and communication with stakeholders to manage the spread of the virus and prevent disease importation. So what do we need to know about Mpox? Mpox is a rare viral zoonotic infectious disease, meaning it's basically disease of animals transmitted from animals to humans that is endemic in several African countries, including the tropical rainforests of Central and West Africa. The exact reservoir of the virus is still unknown, although rodents, squirrels, and monkeys are suspected to play a part in transmission. The Mpox virus can spread from both animal and human, and animal to human, and also from human to human. Animal to human transmission may occur by direct contact with the blood, body fluids, and skin or mucosal lesions of infected animals. Like I said again, monkeys, squirrels, and rodents. This can happen through a bite, a scratch, handling of or eating inadequately cooked and other products of infected bushmeat, or all these rodents. Human to human or person to person transmission also occurs when a person comes into contact with the virus from an infected human or materials contaminated with the virus, such as clothing and beddings. What are the signs and symptoms of Mpox? These symptoms include fever, headache, body aches, weakness, and swollen lymph nodes or glands, what we call lymph glands, and a typical rash. After about 1 to 3 days of fever, the rash comes out, erupts, beginning on the face and then spreading to the body, with the face and palms and soles being mostly affected. They can also occur in and around the genitals, which is why contact during sex is also among the mode of transmission. Our advice to the public: to prevent Mpox, the spread of Mpox, we strongly urge members of the public to adhere to proven infection prevention and control measures. These practices are essential in limiting the transmission of this virus, and they include: avoid contact with animals that could harbor the virus, including sick or dead animals in areas where Mpox has been confirmed. Avoid contact with any materials that have been in contact with a sick animal, especially those animals I've mentioned. Avoid unnecessary physical contact with persons infected with Mpox. Isolate potentially infected animals from other animals. Practice frequent hand washing with soap and water, especially after caring for or visiting sick people. Ensuring all animal food products are properly cooked before eating. The use of appropriate protective clothing and gloves while handling sick animals or their infected tissues during slaughtering procedures or preparations. Report all cases with associated symptoms mentioned above to the nearest health facility for care, and/or call the Ncdc toll-free line 6232. The Nigerian government is making efforts to make vaccines available to the public, especially for the hotspot areas. These vaccines have been shown to have a favorable safety profile. They are not yet in the country, but they are on their way. For health workers, for both private and public, they are further advised to warn: when caring for patients, always follow standard safety measures, including preventions against droplets, regardless of their diagnosis. These steps are crucial for protecting both patients and healthcare workers. Wash your hands with soap and water after contact with patients and/or their environment. Maintain a high index of completion for Mpox, especially for patients presenting with fever or this typical rash, vesicular or pustular rash, in all parts of the country at this time. During triage, the health workers are to use precautionary measures such as placing a surgical mask over their nose and mouth of the suspected patients and covering any exposed skin lesions with a sheet or gown. Isolate all patients suspected of having Mpox as soon as possible. When we say isolate, we didn't say they should send them to isolation centers. But most facilities, that's what we've told the state commissioners, all their facilities, especially those hospitals, whether general or teaching hospitals, they can delegate a particular area as isolation centers or isolation units where they can keep these patients until full diagnosis and treatment is made. Wear personal protective equipment, gloves, gowns, and masks before close contact with suspected cases and dispose this properly after use. Correctly disinfect all contaminated equipment, including beddings, using bleach unless otherwise indicated, and dispose of all waste properly. Report all cases to the state epidemiologist or local government public health department immediately, or call the Ncdc toll-free line at 6232. Samples taken from humans for investigation of Mpox should be handled by trained staff and sent to the Nigeria Center for Disease Control or the designated laboratories. The National Mpox Technical Working Group, which is a multi-sectoral body housed within Ncdc, will continue to coordinate Mpox response activities. As part of these ongoing efforts, we are intensifying surveillance activities, that's tracking cases across Nigeria to swiftly detect and respond to any new cases. We are working with the Port Health Services. Along this line, 5 designated international airports and some key seaports, including land and foot crossing borders, have been placed on high alert. Declaration forms have been distributed to airlines, especially those coming in from countries where there is an ongoing outbreak of Mpox in the last 90 days. Treatment protocols and diagnostic tool protocols according to the IDSR are now distributed to various states. All states have also been put on high alert, including Lagos, Abuja, Enugu, Kano, Rivers State, Cross Rivers, Akwa Ibom, Adamawa, and Taraba. Those are cases, again, where Mpox have been detected. They've been put on high alert. Additionally, we continue to provide health workers and public with updated guidance on infection prevention and control measures, as well as trained surge staff as part of our preparedness and readiness for Mpox public health events. To explain this again, we are starting training of key staff in those states using our response teams, and also some staff that are being activated now by the Port Health Services on how to detect or address these patients. Ncdc is also notifying public and private hospitals about Mpox alert, and we are sending a list of reference laboratory networks. These include our National Reference Laboratory in Abuja here, the CPHL laboratory in Lagos. We also have laboratories in Naima in Lagos, Luth, SGID, I will give you the full name of SGIDs now, UNTH, University of Nigeria Teaching Hospital, and University of Port Harcourt Teaching Hospital. These are facilities or hospitals that have laboratories that have the capacity to test for this Mpox. We will continue to add more from time to time as we get those others ready. We are also considering vaccination efforts for high-risk groups, as Nigeria we're expecting to receive about 10,000 doses of the new vaccines that have just recently been approved for emergency use, and NAFDAC conveyed this to us again not too long ago. We also meet with our various international partners and collaborating agencies like Ministry of Environment and Ministry of Agriculture under the One Health platform for support and coordination efforts. The technical working group remains committed to providing evidence-based guidance to inform the country's next step in safeguarding the health of Nigerians at national, state, and local government levels. Now, there's a particular thing again with Mpox, and that is the need to respect patients' privacy. Because of the legions of Mpox, some people may feel their privacy violated, and that's why we're expatiating on this. Always seek informed consent from patients before their photographs are taken, and state the intended use of such photographs if taken. Do not photograph a patient or any part of their body without their knowledge, and if consent is not given, to do so. When consent has been secured, do not take a patient's photograph with the patient's face in it. Try as much as possible to cover the face. As if of unavailable, ensure to conceal the patient's face before using the image for any purpose. It is advised to get closer to the patient taking a shot that fills the frame. Avoid wide frame pictures that may capture other identifiable items or structures in the frame. And do not share photographs taken on social media. Now, on cholera, cumulatively, as of August 11th, 2024, a total of 5,951 suspected cases and 176 deaths have been recorded across 36 states and FCT, and including 152 local government areas, with a case fatality rate of 3%. Like I said last time, this case fatality rate is totally unacceptable to us. This data reflects a continued increase in the number of cases being recorded across the country. So far, the most affected age groups are those age groups less than 5 years of age. The trend of suspected cholera cases anticipated to exhibit fluctuations and may persist until epidemic week 37. This projection is consistent with the patterns observed in cholera outbreaks in Nigeria from 2020 to 2024. The current rainfall forecast suggests that there may be an increase again in the number of cases. Contributing factors to this outbreak include high rates of open defecation, like we said before, which leads to contamination of water sources through the runoff of fecal matter. In response, we will continue to enhance both prevention strategies and case management measures to effectively address and mitigate the outbreak. Ongoing activities in cholera response also include the implementation of a coordinated response led by the National Multi-Sectoral Technical Working Group for Cholera at this time. It's still ongoing. The National Rapid Response Teams have been deployed to key 6 states reporting the highest number of cases, and these are Abia, Katsina, Lagos, Bayelsa, Ebonyi, and Zamfara. And we will continue to provide support to other states as needed. Rapid response teams deployed to the states actively conduct case searches in high-risk local government areas to identify and link individuals with suspected cases to appropriate treatment centers. Is this active case search again that actually detecting more cases in all these states, because some of those states were not reporting as appropriately? This proactive approach ensures that cases are promptly identified and receive the necessary medical attention, helping to effectively contain the outbreak. We're also doing case management data validation, harmonization across treatment centers. We are providing on-the-job support to treatment facilities on case management, data entry, validation, and reporting. There's also ongoing sample collection of all water sources and food samples in all the affected local governments. We inspect water production facilities and collect environmental samples. This is also being done again in conjunction with the Ministry of Water Resources. Supported ongoing testing across state-level laboratories as Ncdc National Reference Laboratory, Abuja, and CPHL in Lagos. There's ongoing training of laboratory staff on sample collection, diagnosis, and reporting. We are also distributing essential response commodities to all cholera-affected states. Now, on antimicrobial resistance. Antimicrobial resistance is a major global health challenge arising when infections from germs such as bacteria, fungi, viruses, and parasites become difficult to treat with drugs designed to kill them. This undermines the effectiveness of antimicrobial, resulting in infections that can no longer respond to conventional treatment. A 2019 report highlights the severity of this issue, noting that AMR was responsible for about 4.9 million deaths worldwide, with 1.27 million of these deaths directly attributable to antimicrobial resistance. In Nigeria, AMR has contributed to over 65,000 deaths, with a particular grave impact on children under 5 years old, who account for 1 in 5 of these fatalities. AMR is driven majorly by human behavior, such as irresponsible use of antimicrobial drugs, lack of laboratory tests before antibiotics are prescribed by prescribers, inappropriate prescription of antibiotics and use, increased circulation of substandard and fake drugs, poor personal and environmental hygiene and sanitation, use of antibiotics to enhance growth in animals, and poor access to quality health care services. These behavioral issues can render antibiotics ineffective. To address these challenges, NCD is leading a multi-sectoral national AMR governance structure to ensure a comprehensive stakeholder approach to effectively implement Nigeria's AMR strategies. These strategies are focused on improving public awareness and education on AMR, promoting the responsible use of and access to quality antimicrobials, and enhancing evidence-based AMR surveillance across animal, human, and environmental sectors. Additionally, we are strengthening infection prevention and control, biosecurity, and promoting water sanitation and hygiene. Some of the strategies that could be used to change human behavior in Nigeria in respect to AMR, we are continuing to train healthcare professionals to prescribe antimicrobials appropriately and use laboratory results for treatment decisions. It is very essential for doctors to get laboratory confirmation before instituting antibiotics. You understand that what we do nowadays, even the commonest thing now, somebody who has fever and the person is treated for malaria and typhoid. These are major causes of AMR. Most of these antibiotics we use now have been found to be resistant. And that's why, again, people keep going back and forth to hospitals. We are educating farmers through the Ministry of Agric about the risk of using antibiotics for animal growth to encourage safer practice. The youth engagement activities involving 75 secondary schools were supportive to establish active AMR clubs across 6 states. To start with, that's Lagos, Osun, Taraba, Rivers, Kwara, and Nasarawa. About 35 universities are engaging on AMR awareness through their national AMR intervarsity clubs. Information and experience sharing to promote good practice among practitioners through a virtual community of practice. AMR communication training for journalists is being planned to enhance coverage and quality of information shared with the public. Ncdc will leverage the COVID-19 experience, radio jingles, telecom, social media handles to support disseminating AMR awareness messages nationwide. What I'm trying to say, in fact, is that a lot of activities are going on AMR that people would not know, and that's because awareness creation has not been effective. And this is what we intend to start right now. Finally, the NCDC has developed a functional disease seasonal calendar that highlights when the risk of specific disease is most likely to be low, moderate, or high, or very high throughout the year. That is, linking the risks to timely, specific preparedness and readiness actions. Given the predictive nature of this calendar, we are taking proactive measures to address potential outbreaks, especially of yellow fever, Lassa fever, and CSM, cerebrospinal meningitis. Lassa fever seasonal calendar indicates that cases will be moderate in September, with a slight increase in October and November, and peaking in December, January, and February, and they start dropping again in March and April. These are the dates throughout for the calendar. For yellow fever, cases will be moderate in September again, with a slight increase in October and peaking in November. Then they start dropping in December. Cerebrospinal meningitis, we expect cases to be moderate in November and December, with a slight increase in January and February, peaking in March and April, and they start dropping in May. So we are putting systems in place to allow the public and other stakeholders on the necessary preparedness and readiness actions to manage these potential risks. We will continue to, one, advocate to sub-national level emergency preparedness and response committees to mobilize resources for space-specific preparedness actions. I just had a meeting with the State Commissioners of Health just before this, and these are some of the things we passed on to them. We are getting, they themselves at the state are so putting them in the states of readiness. They are supposed to set up their EPR committees in those states. We also do provision of medical countermeasures to support prevention, detection, and responses. This includes stockpiling of medicines, reagents for laboratory detections, and IPC materials, infection prevention and control materials. We are conducting refresher training for rapid response teams to support outbreak responses, as well as hire such staff when required. Like I did say for Mpox, the Port Health Services have a database of such staff they've used before during COVID, and they're activating such database again with a view to getting those contacts and getting them ready just in case they are needed. We're also advocating to professional health associations, NMA, nursing associations, laboratory service application, midwife, NARD, PSN to raise the index of suspicion amongst their members. We will continue to conduct regular community engagement with relevant stakeholders in hotspot communities. We also use multi-channel approach in the dissemination of social behavioral change communication materials, hold town hall meetings with community stakeholders in hotspot communities, and continuously broadcast jingles and dramas on radio and TV at both national and sub-national levels. Some of these materials are being modified and amended, updated. We will send them out either electronically. We've given them some to the state governments so that they can domesticate such things to their various states. Detailed preparedness actions will be shared with all partners and stakeholders at national and sub-national levels for support. We will continue to monitor these efforts to enhance our capability to respond to all these hazards. We remain committed to sharing updates based on new findings and recommendations by other WHO, African CDC, and national Mpox technical working groups. We urge the public to avoid sharing unverified information and not share information shared by either the Ncdc or other official health authorities. I thank you for listening.